Hey everyone, and welcome. Over the next few minutes, we are going to fly through the absolute most critical medical updates from this past year. Now, if you're gearing up for Norect, you really need to lean in close. Why? Because these topics almost always pop up as 2 or 3 direct questions on the exam, making this info absolutely non-negotiable if you want to succeed.
So, let me just ask you straight up. Are your notes actually up to date? Because relying on old info, from last year's coaching sessions or those slightly older textbooks, well, it's a huge risk. These changes are fresh, and not knowing them means you could be leaving easy, gettable points on the table.
All right, so here's our game plan for this briefing. We're going to hit the new way to think about asthma, get the latest on hypertension and trachoma, cover a massive shift in postpartum hemorrhage management, go over key updates in BLS, and then do a quick fire round on the new meningitis goals and some important new drugs. Okay, let's just dive right in.
First up, asthma. The Global Initiative for Asthma, GINA, they've put out some really game-changing updates in their 2025 guidelines, and it specifically changes how we handle mild asthma.
Okay, this slide right here shows a fundamental change in thinking. We are moving away from the old school method of just using a SABA, a short-acting beta agonist for mild asthma. The new guideline now says we should be using a combination, a low-dose inhaled corticosteroid, or ICS, with formoterol. And the big idea here is that this new way actually tackles the underlying inflammation. It's not just a Band-Aid for the symptoms.
So this new approach is laid out in 2 tracks. Track 1 is the preferred route, and it's called AIR therapy. That stands for anti-inflammatory reliever therapy. It basically means the patient uses that ICS and formoterol combo just when they need it. Now, if that doesn't cut it, there's an alternative. Track 2, or MART, maintenance and reliever therapy, where they use that same combo every single day for maintenance.
And just one more quick thing on asthma. A new drug called depemokimab just got approved. It's a subcutaneous shot that's only given twice a year, and it's specifically for people with severe eosinophilic asthma. That's definitely a name you'll want to file away.
All right, moving on to our second section. We're covering some pretty important news on both hypertension and trachoma. I know there's been a little confusion floating around about these updates, so let's get it all cleared up.
For trachoma, you have to know the difference between 2 separate WHO announcements. This is key. First, back in 2014, the WHO announced that trachoma was no longer a global public health emergency. But more recently, they made a specific declaration that India itself is now trachoma-free. 2 different milestones, don't get them mixed up.
Now for hypertension. The American Heart Association has changed up its terminology. What we always used to call hypertensive urgency, that really high blood pressure but without any signs of organ damage, is now just called severe hypertension. Now, what's super important to remember is that the term hypertensive emergency, which is when there is organ damage, has not changed at all. This is just a name change for the urgency category.
Okay, time for our third topic, a major rethink of postpartum hemorrhage, or PPH. You're going to want to pay close attention here because these WHO updates are massive and practically guaranteed to be on the exam. They cover both how we define PPH and how we manage it.
The very first number I want you to burn into your brain is 300 ml. This is a brand new blood loss number for diagnosing PPH. But hold on, that's not the whole story.
So here's the full picture. The new WHO definition for PPH is a blood loss of 300 ml or more, plus any one of these clinical signs of instability. Now, crucially, the old definition, 500 ml of blood loss, is still valid all on its own. The real power of this new 300 ml rule is that it lets you diagnose PPH so much earlier, right when you see those vital signs start to dip. And to help standardize care, the WHO has introduced something called the MOTIVE Bundle. Think of it like a comprehensive checklist for managing PPH. It stands for massage of the uterus, oxytocin, tranexamic acid, IV fluids, vaginal tract inspection, and finally, escalation of care if that bleeding just won't stop.
This brings us to 4 huge updates in the active management of the 3rd stage of labor, or AMTSL. 1. You only use one uterotonic agent, and oxytocin is the one you want. 2. Delayed cord clamping for 2 to 3 minutes is now the standard. 3. Controlled cord traction is now considered optional. And 4, and this is a big one, sustained uterine massage for prevention is no longer recommended. The big takeaway here is the shift from just routinely doing something to routinely assessing the uterine tone.
All right, on to Section 4, key changes in basic life support.
This is the hands-on stuff, the practical skills with updated guidelines that you absolutely, positively have to know.
For neonatal resuscitation, the guidance is now crystal clear. The two-thumb encircling hands technique is the way to go for chest compressions. The old two-finger technique is explicitly no longer recommended. Simple change, but a vital one to get right.
For choking in an adult or a child, the protocol has been tweaked. If the person can still cough, definitely encourage them to keep coughing. But if it's a complete obstruction, you now give alternating sets of 5 firm back blows followed by 5 abdominal thrusts, and you just keep that cycle going.
Now, the infant protocol is similar, but there's one critical difference. You still give those alternating sets of 5 back blows, but you follow them up with 5 chest thrusts, not abdominal thrusts. That is a crucial distinction that's all about keeping the infant safe.
All right, let's wrap this thing up with our final section, a lightning round covering the WHO's new roadmap for meningitis and a few other key drug and tech updates that you need to have on your radar.
So, the WHO has set this really ambitious goal of defeating meningitis by 2030. And the 2 key targets to remember are a 50% reduction in cases of vaccine-preventable bacterial meningitis and a 70% reduction in deaths from it. Those are some big numbers.
When it comes to diagnosing this, the clock is always ticking. The investigation of choice is a lumbar puncture, and it is absolutely critical that you get those samples before starting antibiotics. But the most important window to remember is this. You have to begin antibiotic treatment within 1 hour of first suspecting meningitis. That's the golden hour.
And finally, just a few rapid-fire updates to finish us off. For malaria, remember the new R21 vaccine, and know that there's growing resistance to artemisinin-based therapies. For PSVT, there's a new nasal spray called etripamil. And for depression, a new term to know is FL100, which is transcranial direct current stimulation, or TDCS, for those moderate to severe cases.
And there you have it. It's just such a powerful reminder that medicine is always changing, always evolving, and keeping up with all this stuff isn't just about passing your exams. It's about being able to provide safe, excellent care to your patients for your entire career. So, as we wrap up, I'll leave you with this question. Now that you've got all these updates, which one of these changes, whether it's the new asthma protocol or the BLS updates, do you think is going to have the biggest impact on your own future practice? Something to think about. Thanks so much for tuning in.